Hi, I'm Dr. Pierce Sr., and it's nice to have you with us today. I always enjoy the opportunity to talk to students because, frankly, that is where we are most excited about this work. You receive a lot of different opportunities to be exposed to lots of different techniques and procedures in college, but very seldom do you really get the opportunity to really focus and detail out in a procedure. The work that you're going to be hearing about here is called the Advanced Orthogonal procedure. And actually, the Advanced Orthogonal procedure developed from a long chain of events in upper cervical chiropractic back into the days of Grostic. Dr. John Grostic started teaching his procedure back in 1946. And he, of course, was the very first one that initially brought forth the orthogonal concept of balancing the head over the cervical spine and balancing the atlas between the two of them in basically a right angle type of relationship, and that's what the word orthogonal means. But of course now, back in those days, there wasn't any type of technology except for the x-rays, and Dr. Grostic did a great deal of detailed study in x-rays to determine exact patterns of subluxations that patients had, because the upper cervical area was so atypical to all the rest of the areas of the spine. He also developed a hand adjusting procedure that you may have seen by this time in your progress in college, and you might not. It's not really relevant to what we're going to talk about today, except anytime we're doing a hand adjustment, we try to be as specific as we can, but we very seldom can get the exact angle, for example, when we set our body up to make an adjustment on the upper cervical area. But we start out with a side posture table with a stationary headpiece. It wasn't the drop headpiece with Grostic. And the x-ray analysis gave us the exact misalignment patterns, and it gave us actually resultant vectors to try to align our body to when we were actually making the adjustment with our hands. That worked well for some people. A lot of people went to the Grostic seminars and were very dedicated and worked very hard at trying to develop the hand adjusting procedure. However, very few people really got to the point where they could duplicate that adjustment very well. Also, it was quite strenuous. Many times people strained their low backs and sometimes even injured the disc with very busy practices. Some doctors will end up, after years of doing the upper cervical work with the Grostic adjustment or the Nuka adjustment also by Ralph Gregory, were having problems with their heart and shoulder issues. And so there was a lot of complications in trying to do a very specialized adjustment by hand. I started out in the Grostic technique when I graduated from Palmer College in 1967. And my dad had been a Grostic chiropractor. I was raised under Grostic chiropractic, in fact, and I never knew what other adjustments were. I just always had my neck adjusted when anything was wrong, and I always had great health. And that's why I chose to follow in the Grostic line of practice when I graduated from school. I attended seminars twice a year relentlessly to try to perfect my skills and talents, and frankly, I got to where I could make pretty good Atlas adjustments and had great results with most all patients and built a very good practice with the Grostic procedure. But as time went on, Dr. Roy Sweat in Atlanta, Georgia, he started thinking about a concept of maybe getting an instrument designed to try to duplicate that hand adjustment, and maybe more people could have an opportunity to do really good specific upper cervical work and not injure themselves while doing it. And in the late 70s, there was actually one instrument that was made by a company called, I actually forget the name of the company, so much time's gone by since then, but it was actually an excursion instrument where the instrument actually did an excursion type of adjustment, and you could preset that instrument to anything from 1/8 of an inch up to 1/2 of an inch of depth. And after we researched with that for 1 year, we got together and pooled our concepts, and we found that we actually were not getting very accurate corrections when the instrument was actually excursioning into the neck at the transverse of the atlas. And I personally kept reducing the depth of the instrument all the way down to that 1/8 of a setting. And then actually I moved the instrument just off the skin, and it would actually peak right at the skin when it would make the adjustment. and I found that I was getting better corrections and better reductions on the post x-rays. Of course, post x-rays are very, very important because they tell us what we did right, they tell us what we did wrong, and they tell us what we need to do to make the adjustment better the next time we adjust that patient. So after that period of time with that excursion instrument, it was one doctor designed actually an instrument that had a stationary stylus. And there was a percussion wave that was generated down that stylus. And I purchased one of those instruments and started working with that and found that actually we got the most refined corrections with the percussion wave adjustment rather than the excursion adjustment. And so from the very early 80s, we used percussion wave adjusting. There were different companies that made different kinds of instruments that tried to duplicate this type of thing, and we purchased the different types of instruments and worked with them, and we found the Spinalite company made the most consistent instrument that we liked, and found that we got the most consistent results with. In the mid-90s, we started doing additional research with X-ray analysis, actually. Started doing additional evaluations of condyles and aberrant condyles and aberrant anatomy in the Atlas area, because there was always missing links that we sometimes didn't seem to get the right corrections that we wanted, and we weren't always sure why it didn't go as well as we thought it should. Even in the days of Grostic, Grostic had very specific table placement procedures to coordinate with the biomechanics of the upper cervical area. And we continued developing that table placement procedure, and it did help us to get more balanced reductions in the post x-rays. But we also found that there were some missing links in the x-ray analysis, and as we continued to research more and refining the x-ray analysis, we also found that we need to refine our table placement procedure in order to get the more precise correction in the upper cervical area. I think most all upper cervical doctors would like to have the perfect adjustment for every patient and make one adjustment, and that adjustment would give the right correction and the patient sustain the correction and consequently would regain their health. And that was always a goal of mine from early on. But once we got into the advanced concepts where we were doing much more refined analysis in the x-rays, which you will get in this course, we found that we needed to have a much more refined table placement procedure, and the tables that we had did not afford us quite that freedom to be as precise as we wanted to be. And so I personally coordinated with the Spinalite company at that time, it was owned by Mr. A.T. Cox up in Kennesaw, Georgia, I believe it was. And I told him specific things I wanted to incorporate into the table to help us place the patients better. For example, we designed a movable shoulder section that when the patient would lay on their side, this section of the table there would actually move forward and back and up and down, and we could precisely set the shoulders in a more precise position to affect the proper correction when we made the adjustment. That was extremely helpful to us. We also remodified the brackets underneath the headpiece because in some types of patterns that you will see when you get into this work, the shoulder actually has to be placed quite a bit up underneath the headpiece in order to influence the biomechanics in the upper cervical area. So we changed the way the bracket was made underneath the headpiece so we had more room to position the shoulder there. Another very important part of the positioning of the patient on the table, of course, is the way the headpiece support is underneath the patient. And if the mastoid, for example, is not stabilized correctly from the x-ray analysis, you can see exactly how the shape of the mastoid is, and you want to be sure the mastoid is stabilized. And we did make a slight modification in the material that we had under the mastoid support to make it a little more stable. To some people it may feel a little firm, but it has helped us a lot in getting a more stable support underneath the mastoid. The next thing we did was we were considering the alignment of the instrument to the patient. And when we placed the patient on their side on the table, we did try to set the head so it is kind of on the right angle to the headpiece, but very seldom did we actually find that we all could set the patient right on the zero line of the table. and that the patient's head placement was actually a little different than what the zero line was on the table. So you couldn't use reference to from the protractor on the headpiece when the patient's head was not sitting exactly on that zero. If the head was tilted back a little bit, their zero line of their head, which comes from their nose through their ear, an exact right angle up to it, it may be crossing 5 degrees to the posterior of the zero on the headpiece itself. So we designed an instrument to find out exactly where the patient's zero line was when they were positioned on the table, so we could set the correct rotational vector when we were lining the instrument to the X-ray measurements. This was very helpful in getting a much more precise correction, and consequently we didn't have to keep doing repetitive adjustments to try to get the rotation better with the patient. We found the one adjustment could get the correction made properly. Other aspects about the table itself is that the shoulder section itself moves with a joystick that makes it very simple to position the patient. You don't have to keep moving the patient yourself and wrestling with even some of these rather big people or heavy people, or if you're trying to make just a little slight change in positioning, it's very hard to try to change them with your hands, but you can just simply touch that joystick and make those little refined positionings of the patient to influence the right biomechanics. So when you adjust them, you want the spinous to reduce correctly, you want the lower cervical spine to reduce correctly, and that's a big help with the shoulder section itself. Other things that we're concerned about are some outside things after the patient is positioned on the table. For example, once they're lying there with the head on the headpiece, very seldom do we find that they are laying exactly parallel to the table. Usually from where the center of their neck is and the center of their head is, they're laying on a little slight incline. This, of course, varies from things in the X-ray analysis that you'll learn as to how high or how low you will have that headpiece set to support the head in the proper position to influence the right outcome in your adjustment. But once that is set, we actually started measuring the exact angle the patient was laying at. And then once we had that measurement, then we knew exactly how much angle we had to set on the headpiece. For example, if the X-ray said that we had to set the instrument angle at 25 degrees, and if the patient was already laying on a 10-degree angle, well, we would reduce the instrument setting to 15 degrees. So if they're on 10 and we set the instrument on 15 degrees, now we're adjusting them on 25 degrees. That's the exact measurement of the X-rays tell us to get the right correction, and we found that we get better corrections when we utilize that measurement. So all in all, we've come to a point in this procedure where we have minimized a lot of human error and put things into the realm of technology with the computer analysis for the X-rays and the three-dimensional plane with the digital X-rays that we analyze the structure. We teach you exactly how to do the table placement as you relate to the biomechanics that you found in your X-ray analysis for each patient. And you find that each adjustment is almost like a separate fingerprint adjustment for that patient. But the goal that we've always had in upper cervical chiropractic is to make the right adjustment, get the right correction, and have patients hold those corrections. Because when patients hold adjustments, nerve systems function better and bodies heal. And that's why we're at a level now where we are getting consistent results almost on a regular basis with each adjustment that is made. And some patients have held these adjustments for months and sometimes years when they are done correctly. So I hope as you get into this work and study the detail of this work, I think that you will find that if you're going to do Atlas adjusting, you want to do the most refined adjusting that you can do. And I would recommend to you the advanced orthogonal procedure. Good luck, guys.